All right, good morning. These have been fantastic talks. We've had surgery and non-surgical talks. This is going to be not so much about cool surgical techniques. It's narcotic avoidance in sports and shoulder surgery. And this is really one of our areas of excitement and passion. I look out on this room. Many of you have participated with me in the last 5 years and been on this team where we really try and address this problem. The scary facts about this problem, and it doesn't seem to change. In 2014, we had more drug deaths from overdose in any year in record. In 2017, we had 70,000 overdose deaths. This is more than motor vehicle accidents. In 2019, the life expectancy in the United States continues to fall for the third year in a row, primarily related to young people dying. You add that to a third of prescription narcotics that are given rightfully, at least thoughtfully, rightfully by doctors, go unused. And that concept of diversion of medications, when a medication that is appropriately prescribed to somebody is then used or misused in an alternate setting. So these are our scary facts. How do we combine that with shoulder surgery? Dr. Kowalski showed us some amazing slides of exciting surgeries that we do, but guess what? It can be very painful, or at least I'm going to argue it used to be. This concept of rebound pain, when your nerve block wears off, your patients can be very uncomfortable. We want to try and limit some of the non-steroidals after surgery because they may interfere with healing. This is what we get the most phone calls for. And if I look at rotator cuff surgery, it is the shoulder surgery associated with the most OME. OME is a standardized way of talking about how much opiate or how much narcotic we're going to use. And if you look at the national data, patients on the average will use 70 pills. 70 pills for this given surgery. It sure seems like a lot. So the challenge that we've faced ourselves with our team here at ONS is that we have poorly controlled pain. We have no formal education for doctors, nurses, nor patients on how to control pain. We have no evidence-based guidelines. And we have overprescription, we have diversion, we have dependence, and worse than that, addiction, and we have a crisis. But this is a little bit of a battle because we're in a world now where patients are going to rate their pain scale. Their pain score is going to correlate with the immediate requirement for delivering narcotics, which may not be right. And at the same time, we need to balance this with reviews and surveys. Not only do we have to ask and be satisfied with patients' food and blankets, but we're somehow getting reviewed on how well we treat pain. So this is going to be a challenge for us as doctors. Where do we learn? Where do we learn to prescribe? Well, we looked at a study and we asked 75 orthopedic surgeons where they learned to do these things, where they learned how to prescribe. And as it turned out in that study, more than 50% said, no, we really didn't learn this. And only a small percent actually had any formal knowledge of that. And that was just from attending to resident, sort of passed on knowledge, which in and of itself is dangerous. If we look really carefully at the orthopedic literature, what are the recommendations concerning rotator cuff repair? Well, there's two types of recommendations that exist out there. There's observation, meaning Dr. Vitale did this many surgeries. As he looked back on his patients, the patients took on the average this many. They consumed this many. And the second type of study is the Delphi analysis. A Delphi analysis is when you put a wise group of people in a room and you sit down and they scratch their heads and they say, this is what we think. So observation and Delphi analysis are as good as it gets for how we should write opiate medications after shoulder surgery. And if we look really carefully at what's published, and this is from a New York City institution that came out in 2019, and they suggest for certain surgeries, for certain surgeries, specifically for rotator cuff surgery, 60 tablets. This is 2019, this is current data, this is one of our best respected journals, and this is from a top institution in New York. 60 pills. So that's right on line with what the literature suggests. If we look more carefully at what shoulder surgeons are actually doing, going back to an observational study, on the average, 36% of the pills in shoulder surgery are not being used. And if we ask very carefully, what's a complication rate after surgery? Well, you know what, I'd be happy with a 1% rate of infection or a smaller re-tear rate. But if it turns out my complication rate is 20%, I'd better ask myself, what am I doing? Well, looking at rotator cuff patients, 20% of patients will be on opiates at 180 days. This is stupefying. So the challenge that this group that you're here with today said, look, how can we reduce the number one complication of rotator cuff repair? And that number one complication is being on opiates for a prolonged period of time. So we thought to ourselves, we're going to create a protocol. And not only are we going to create the protocol, but we're going to measure the results. We're going to have consistent preoperative medications, consistent medication in the operating room, consistent medication after surgery. So we started it. We initiated our protocol, and we decided we would indeed measure our outcomes. And we measured them with the pain journals that the patients filled out, opiates use, pain scores, and patient satisfaction. We wanted to believe that our surgical skills, whether we did your rotator cuff with 1 row or 2 rows, and we were really slick and fast at surgery, we thought that would really matter, and we tried to include that as part of the ordeal. But as it turns out, the first most important thing that we did is we worked on education. In a study done from Emory in patients undergoing ACL surgery, simply by reducing the number of pills, patients took fewer pills. Furthermore, by adding education, you turn their pill consumption into half. So education, setting the expectation, not you should take these medicines to get ahead of the pain, rather wait till it hurts till you take this medication. We went with no refills. Boy, that's not very nice, no refills. Where is our compassion with this? Well, what should you know about refills? Well, if you're on a medication more than 8 days, you have the risk, an opiate medication, of being on that medication at a year, 13.5%. So more than 1 in 10 will be on it a year later. Refills, every time you refill that medication, you increase the chance of a dependency at a year by 44%. So no refills, not no compassion. Actually, we care about you. So did it work? Did this rotator cuff study work after using education and a constant multimodal? Well, here's the first image looking at the pain. What was people's pain really like? There's an orange line and a blue line. Really what you want to look at is the amount of pain. The VAS or their pain score was much lower in the patients in whom we started doing a consistent protocol in a substantial way. Furthermore, if you look at the opiate consumption, without getting too nerdy about it, it's the amount of area under the blue line or the area under the curve in the orange line. Statistically significantly important. And once again, we looked at this and we had a 64% reduction in opiate consumption in the patients in whom we initiated this protocol. We published this in the Journal of Shoulder and Elbow Surgery, and we're very excited about it. We were the first ones to look at evidence-based guidelines, and we found that we recommended on this study 25 tablets. Unlike the 70 that the national population is getting, unlike the 60 that was published from a major institution in the very same year. Does this apply at other centers? Are we just special? Do we do it? Do we have a privileged group of patients who we have the opportunity to take care of? So we decided to look at this at other centers. Here, in another study that we presented at the American Shoulder and Elbow Society just a few weeks ago, we took a group from Connecticut, a group from Florida, and a group from Oregon. And we prospectively looked at, can we control pain in a better way? And looking specifically at rotator cuff surgery, our protocol, even when we varied it slightly with medications based on geography, looked at patients taking minimal opiates, having minimal pain, and their pain scores never got above a 3.5 or a 4 through the entire surgical procedure. Once again, our theory of 15 to 25 pills, irrespective of geography, held true. What's next? Well, we decided to look more carefully at what medications we can do to get better at this. And we added in special injectable things at the time of surgery. Now we're down to 4 or 5 pills. 29% of patients went with 0 opiates after surgery. We'll talk about that more a little bit. It's a neat badge, but not necessarily the most important thing. Once again, the protocol demonstrated that we can get away with 15 pills, not 60, not 70, 15 pills for 92%. Looking at pain scores once again, data published at the American Shoulder and Elbow Society, our patients are really doing well. We took this to total shoulder replacement. Can this work in a joint replacement? If you asked me 15 years ago, can I do a joint replacement, a shoulder replacement? Can I do it as an outpatient? And can I do it in a way where the patient says this was not a bad experience? I would have said, no chance, this hurts, you've got to stay in the hospital 3 days, go with us on this. Well, we looked at this at our center first, and then we took it to a multi-center evaluation once again, and we found that our patients on the average needed about 10 total pills after joint replacement. So it's not just us. Other authors have actually published on opiate-free surgery, and we looked at a couple of our patients and asked them their experience on this. So let's see what they have to say. How many days did you stay in the hospital?
None.
And how many pain pills did you require after surgery?
I don't think I really required any after surgery. I took 2 pain pills, because you had told me that, to get ahead of it in case there's...
I told him. All right, what about her?
Hi.
Can you please describe how much pain you had after shoulder replacement?
It was amazing. I had none. I actually took no pills whatsoever. It was perfect.
Can you please raise your arm up for me?
Absolutely. No problem.
Thank you.
You're welcome.
I didn't do
Dramatically
that one.
better.
Any pain?
Zero pain doing that. Little, it's tight trying to go behind me.
Okay, come
It's
on.
not painful, but it's tight.
All right, let's talk to her.
Hi, my name is Karen. I had a total shoulder replacement 9 days ago at Greenwich Hospital with Dr. Sethi. I have taken 0 opioids and I have experienced 0 pain in my
So
shoulder.
how is that possible, right? It doesn't seem like it's possible, and I probably got 70 or 80 more of these videos that I keep on my phone, and my kids don't think they're very fun. But it's possible by having a team approach, by having education, by setting expectations, by setting the standard, and that's what we've done very effectively. The last part that we want to talk about, the last 2 parts, is we want to dispose of excess medications. We want patients to know where to put those medications. We want them to know not to keep them in our cabinet. Once again, we are not educated on this, and each community has a separate answer. As you know, in Greenwich, we can send them to the local police station. The last part of our team is start to look at this in knee arthroscopy, and once again, we are going to reject the 29 standards in the published journals. We've just received word that the American Association of Orthopedic Surgeons and the Journal of Arthroscopy have accepted our paper on saying that for knee arthroscopy, we believe that between 0 and 5 pills is the right number. So, look, the final message that I have for here: take ownership of this problem. Have the discussion with your patients. Set expectations. Have a consistent multimodal program, write fewer pills, and we here are giving you published, peer-reviewed, evidence-based guidelines. Thank you.